Good evening and welcome to tonight's CPD webinar, Optimising Chronic Lung Disease Management, a Functional Approach. I'm Dr Anita Munoz, a GP and medical educator, and I'm delighted to be your moderator this evening. On behalf of PraxHub, thank you for joining us from across Australia. I'd also like to acknowledge that this education has been sponsored by 4D Medical. We're grateful for their support of this important subject area. We've all had those patients who keep coming back. They're breathless, it's affecting their life, but the basic tests aren't showing us why. It's frustrating for us, but even more so for them, as they bounce between appointments without clear answers. This is the second session in our two-part webinar series, and I'm joined once again by respiratory physician Dr Paul Hamor and radiologist Dr Dean Rabinowitz. In this session, we're focusing on patients who are persistently breathless, despite unremarkable basic tests. Our speakers will take you through the broader differential diagnoses to consider at this point and share a practical investigation strategy you can follow, even when specialist appointments are months away. You'll see how to apply these principles to the complex patients with multiple conditions that we're really seeing in general practice. Crucially, you'll learn how to develop management plans and determine when it's time to push for specialist review. Now, let's get started. So over to you, Paul.
Thank you, Anita, for that kind introduction. It's nice to be back here to present the second part of our webinar series on breathlessness. Today, we're going to discuss a few case scenarios and discuss more about chronic disease and how breathlessness can affect different scenarios. But hopefully with the cases that we present might get you thinking a little bit outside of the box for some causes of breathlessness that might be a little bit atypical. So look, let's recap what we learned in the first webinar and look at these first principles for how I think about breathlessness. And essentially, the breathlessness can be caused by an oxygen molecule out here that needs to be delivered down to the muscle, down in the legs, and anything that impairs that process can contribute to breathlessness. So starting in the airways, we think of the airflow in and out. Asthma, COPD might do that. The muscles of respiration will contribute. Then that oxygen molecule will then need to get into the bloodstream. The blood needs to be carried around on hemoglobin, needs to be then pumped around the body by the heart, and then the muscles need to utilize that effectively. And so if you want a bit more information on that, have a look at the first webinar. I highly recommend it. But let's get cracking into this talk. And so there are a few things that are commonly missed when thinking of breathlessness, because I think most people's heads go to the common things like COPD, asthma, or cardiac disease. There are a few things that we really need to keep in mind. So anemia is very commonly missed, and I don't think enough people do just a simple blood test when investigating or thinking about breathlessness. Pulmonary hypertension is difficult to diagnose and sometimes isn't picked up in the first or second screen, and sometimes it's only on repeat echoes that you might see it. But more sensitive is doing an echo at exercise, or sometimes you need a right heart cath with exercise as well. Chronic thromboembolic pulmonary disease that might even be there with a normal CTPA. And that's important to look for when you've got a patient, particularly if they start to desaturate on exercise, or if you have a patient where the lung function tests show that they've got a reduced gas exchange capacity, but their spirometric volumes are normal. Dysfunctional breathing is tricky. I think you could think of it as a diagnosis of exclusion, but there are some clues that some people will have a dysfunctional breathing pattern. And one of the things that I do to look for that specifically is get patients to sit in on the clinic bed, and I just observe their breathing pattern. And I get them to lie down, and I'll get them to pop a hand up across their chest here, and another on their belly there, and just have a look at which muscles they're using to breathe. Are they using their chest muscles or are they using their diaphragm more? And those patients who are using their upper chest more to breathe are more likely to have a dysfunctional pattern of breathing. Unfortunately, it's not specific for dysfunctional breathing, because someone who is struggling to breathe will always switch on their accessory muscles. So it's only useful if you've excluded other causes, looking at that breathing pattern. The next on this list is deconditioning or gait disorders. I talked a little bit about that last time, but if you had a patient who has quite bad, say, arthritis, or they've had hip replacement, or they're waiting a hip replacement, or those who are walking with an antalgic gait, those sorts of patients will be inefficiently using oxygen because they're using muscles to walk that aren't traditionally designed to help with walking. And so if they're walking and utilizing those abnormal muscles to walk, they'll become breathless more easily. Vocal cord dysfunction is very in the sort of similar camp to dysfunctional breathing. Again, it can be a diagnosis exclusion, but can be tricky to diagnose. There are some provocation tests that aren't done very often, but some of the key things with vocal cord dysfunction are that the symptoms seem to increase with stress or lack of sleep, but also can be triggered by smoke, perfumes, or strong smells. Particularly for some reason, cheap perfumes tend to set it off a little bit more, and can very often present like asthma. And I've had, over the course of my career, about 3 or 4 patients who've had recurrent admissions to the intensive care department with intubation for severe asthma. And as soon as they intubate them, they're absolutely normal to ventilate with no resistance, very easy to ventilate, which suggests it isn't asthma. And the intensivists very quickly extubate them and they're fine. And that usually gives the clues that there's some vocal cord dysfunctional, or the vocal cords moving paradoxically on inspiration and expiration that's causing their symptoms. And then lastly, early neuromuscular diseases that impact respiratory muscle strength can also cause breathlessness. Sometimes in some diagnoses, such as ALS or NND, those diseases can affect the diaphragm first. And then if that happens, patients will typically experience some orthopnea and breathlessness on exertion without necessarily having peripheral muscle symptoms first. It's less common, but I have seen it a few times. So here's some of the things to think about when we're thinking about things that are a bit more outside of the box. So how would I investigate this? And one of the things when I was putting together the next few slides is thinking about resource-constrained settings, such as rural practices, but also thinking about sometimes you could be working in Western Sydney and it's hard to get your patients to a specialist. And so you're almost as constrained as, say, someone who might be out in Broken Hill. So these are some of the first things that I start to think about in terms of investigation. So for pathology, full blood count, looking for anemia, electrolytes and LFTs, looking for acidosis, particularly if you look at the bicarbonate. It's a good clue if it's elevated or reduced, that there might be an acid-base disorder going on without having to do a formal ABG or VBG. A D-dimer might be useful to look for pulmonary emboli, and particularly small pulmonary emboli, but beware, it is not very sensitive, and if it's elevated, it may be due to other causes of inflammation within the body. So pair that with the CRP. If the CRP is normal and the D-dimer is elevated, you do need to think twice, and it's more likely to be a real result. TSH with T3, T4, if it's abnormal, to look for thyrotoxicosis. The creatinine kinase, looking for muscle disease. The NT-proBNP, so BNP is beta natriuretic peptide, looking for any signs of cardiac strain. That's elevated in heart failure, but also in pulmonary hypertension. And you might think about doing an autoimmune screen if someone has uh, uh, some features of interstitial lung disease on your exam, for example, fine crepitations. That's something you could do while awaiting referral if someone has interstitial lung disease, to try piece together the puzzle. And then after you've done some bloods, you might start to think of some imaging. And Dean mentioned it briefly, but I think perhaps he can talk a little bit more to it in this talk. But how do we think about what sort of test to order? Now, Dean recommended last time that you have a good relationship with your local radiologist, but some of the things on the menu to order could be a CT chest, HRCT, or even a low-dose CT, or some of the newer scans such as an LVAS with the lung ventilation study. But I might hand over to Dean to talk about how he might approach a general approach to breathlessness and where each of these types of scans fits in. Dean.
Thanks, Paul. Hello, everyone. It's great to be with you again tonight. As a very quick refresher in answer to one of Paul's questions, we have to remember that with imaging, there's obviously situations where there is a need for imaging in an acute setting, and then there's also a completely different menu of tests you might consider in a chronic setting. So we're going to concentrate mainly on chronic because that's the topic for tonight. But very quickly, just to address that there are some acute situations, acute shortness of breath or respiratory illness, trauma, chest pain, various things where you might consider imaging. And mainly as a learning point in these situations, a chest x-ray is almost always going to be the first line test. However, as I've said before, this test does lack sensitivity. So it's not going to demonstrate some of the parenchymal abnormalities that would be the case in a chronic setting. Chronic diseases, recurrent infections, chronic shortness of breath, things like lung cancer screening or pulmonary nodule follow-up. These things require more specific imaging. While a chest X-ray is often used as a first-line test, it's much more common to require a CT in these situations. So just as a reminder, this is a chest X-ray, can't see any abnormality, but the CT identifies pathology which otherwise would remain occult. So CT is the key investigation in chronic shortness of breath, but there are a whole bunch of different ways that we can perform these CTs. In addition to whether or not we perform them with contrast or without contrast, there are different types of reconstructions that the radiographer and the radiologist can use to make different parts of the body easier to assess on those studies. And finally, there are dynamic and functional components to the CT chest that we can add. These things are not things that you can do retrospectively. So in a reconstruction or in a windowing, you can do them. You can apply them to a test that has already been performed. But for functional and dynamic testing, they have to be done prospectively. We have to know in advance that that's something that we're going to be doing. One of the ways that you might be able to work out what the correct protocol is to use the diagnostic imaging pathway. Paul did mention having a relationship with a radiologist is the best way. I totally agree. But if you don't have access to one, or if you want a very quick reference, the diagnostic imaging pathway available online for free is an excellent tool. It's got clinical scenarios that you can use to help you to choose the right test in a particular scenario. And it looks something like this with all the different imaging options. In this case, it's we've got chest X-ray as the first line test. And then as Paul's pointed out, you might do spirometry. And depending on those findings, you might go down the line of either doing HRCT chest or a standard CT chest. So now let's talk about what the different types of CT chest are and why you might choose them in different clinical scenarios. So the routine non-contrast CT chest, this is essentially what we do in a very basic setting where we are just trying to assess what is happening in the lungs. You will get some information about other structures like the mediastinum, but it is principally an assessment of lungs in commonly in situations where you might be screening for major pathology like masses or nodules. It could be in the setting of bronchiectasis, could be in the setting of minor chest trauma. But the important thing is that this is the assessment of lungs. Most of the time, we are able to use a routine non-contrast CT to identify if there is a cause. And if we need contrast down the track, we can always recall the patient and give them contrast if that's going to be helpful in a diagnosis. Now, just showing you here, these are some examples where a routine non-contrast CT chest, we get nice images of the lungs, we get some information about the soft tissues, but it's really, and bony windows, but it doesn't give us the depth of information that a contrast study would. Now, why we might choose a contrast study is if we are trying to assess the mediastinum, or if we are trying to assess soft tissues in the chest, the contrast study really becomes an important part of the test. In addition, if we are suspecting that there might be pathology inside the lung parenchyma, such as an infection or a mass or a empyema, a collection inside the pleural cavity, or some sort of neoplastic or inflammatory condition, those situations, contrast is far more helpful in delineating those soft tissue structures, differentiating things like lymph nodes from vessels. Contrast becomes an important part of the radiologist's toolbox to be able to differentiate between those structures. So things like pyrexia of unknown origin, or a non-resolving pneumonia, or recurrent episodes of pneumonia, when you suspect that there is a mediastinal mass in settings of staging, either cancer or lymphoma, significant chest trauma where we feel like there might be a vascular injury, those situations, contrast is really important. And these are some examples of where the contrast has been able to identify or help in the diagnosis of pathology in the lungs. This is a really excellent example showing you how with a non-contrast study, we cannot easily differentiate between the different structures within the mediastinum. But with the addition of contrast, you are now able to see vascular structures. You're able to see a cystic area here, which is basically an area of necrosis that you would otherwise not be able to differentiate. The other value of a contrast study is that we're able to look at different vascular structures, and the timing will depend on what structure we're most interested in. So if we're looking at the pulmonary arteries, for example, for like this case, a PE, we would do a CT pulmonary angiogram. But if we're looking for pathology in the coronary vessels, we would do a CT coronary angiogram. And if we're looking for pathology inside the aorta, like a dissection or an aneurysm, we would do a CT angiogram. And you can also combine these in order to reduce radiation by doing double and triple rule-out studies. And these types of studies are essentially for the specific purpose of assessing for vascular pathology. HRCT chest we talked about in great detail in the previous session, so I'm not going to go through it all that much other than to say that we choose an HRCT chest. It's a non-contrast study for the most part. We're choosing it in order to look for a diffuse lung disease. And these are things like, it might be interstitial lung disease, COPD. Sometimes we can use it in a case of bronchiectasis for cystic lung diseases. And it's a useful test because it's dynamic. It shows us information about what the lung looks like when it's in full inspiration versus expiration. And by turning the patient into a prone position, we're also getting information about the way that fluid might shift within the lung and mimic pathology inside the lung. This is just an example, again, showing that this mimicking appearance that atelectasis can have in the lungs, and air trapping is quite conspicuous on this expiratory phase. Now, functional studies, these are useful as a way of identifying a potential unseen pathology in the lung. So as you might send a patient off for VQ to look for ventilation abnormality, or perfusion abnormality, we have now developed these different tests like the CT LVAS, which we talked about in great detail in the prior session, which is a very useful test at looking at ventilation defects. And while it's not TGA approved yet, it should hopefully be soon. You might be able to combine the same study for a CT in order to get perfusional information. There are other dynamic tests like Cine-CT and dynamic post-contrast, which have their uses as well. Low dose, I want to cover very quickly because in situations where our interest is simply in what is happening over time, when we've already identified a pathology and we're simply trying to follow up to see whether or not that pathology is remaining stable, resolving, or worsening, a low dose scan is a very useful test. And in some situations, if you think you're going to be rescanning the patient many, many times, an ultra low dose scan where the radiation is significantly reduced is potentially a better option as well, therefore reducing the amount of radiation that the patient will have over the course of their progress studies. We also use low-dose scanning for lung cancer screening, and that's why it's been why our lung cancer screening program has recently been introduced, because we have confidence that we are not exposing patients to unnecessary radiation. And just by way of comparison, standard CT chests end up giving us about 2 to 4 times the amount of background radiation that you would otherwise get in a year, whereas something like a low-dose CT chest, you're getting about 25% of the background radiation. And in an ultra low dose, you can get that to about 5% of background radiation. If you prefer to think in terms of X-rays, that means that an ultra low dose scan is about 2 to 10 standard X-rays, which is significantly less than what you're getting from a standard CT chest. Paul, I hope that's helpful, and we'll throw back to you.
All right, thanks, Dean. I hope that was useful for everyone. I certainly found it useful. Actually, I changed some of my practice because of it. Next, you can consider doing some respiratory assessments in your practice. Even if you don't have a nurse, perhaps some of these might be useful for you to think about, particularly if you've got an inability to refer to formal respiratory function labs. So these are some things you could do. So peak flow. I've got a peak flow meter here. It's actually a really good screening tool for patients. And particularly, they're so cheap that it's sort of $10, $15 from chemists. And if you're trying to get a better sense of what patients are doing with their day-to-day breathlessness, and you can't quite capture it in your office, a peak flow might be useful. There are some patients who will have symptoms through the day, and if their peak flow is normal, might give you some reassurance that it's not asthma or some other airflow obstruction, but it's really only designed for asthma. So that's the first thing. The next is a one-blow spirometry, or what I call a one-blow spirometry. But basically, it's one big breath. It's a bit like a peak flow. One big breath, you blow out as hard and fast as you can. And if all of those parameters on that spirometry is within normal, then it's kind of reassuring that there might not be an airflow component to that patient's assessment. It doesn't exclude all lung disease, but it might give you some reassurance that it's not asthma or COPD at that particular point in time. So that's helpful. Then there's the more formal spirometry pre and post. Now, there is a Medicare item number associated with that, but it is quite laborious and time-consuming to do a pre and post spirometry. Each maneuver needs to be repeated 3 times to get the Medicare benefit item. And then you need to wait 5-10 minutes for them to have some salbutamol, wait for it to take effect, and then do a post. Most of these would be done by a nurse in your practice if they're trained, but even then, it is difficult to get spirometry really good. And so having your nurses, if they're performing this, knowing that they've done an adequate course, and I think the Lung Foundation does offer a training course for your staff if they're interested, but would be a great adjunct to your assessment of breathlessness in your clinic. Next is spirometry, erect and supine. And this is really looking for diaphragmatic dysfunction. So when a normal person lies flat, their lung volumes might drop a little bit, but not much. Certainly less than 10%. But if you've got a fall in the forced vital capacity, say up to 30%, that's very significant. It might suggest some respiratory muscle weakness or diaphragm dysfunction. So that's something that if you've got a portable spirometer is something you could consider if you've got a suspicion of neuromuscular disease. The next is a 6-minute walk test. It does need to be a maximal test, so you really need to encourage patients to walk for the full 6 minutes. It's more useful really as a prognostic marker in certain disease states, for example, in pulmonary hypertension and interstitial lung disease. And it's a useful marker to assess an intervention, both pre and post, in those two diseases, but also in just for rehabilitation purposes. So it does need to be done with oximetry, and you should be assessing a Borg score every minute if you're going to be doing it properly. It's something that physiotherapists often do, and so if there's a physiotherapy centre in your town, if you're working remotely or rurally, it could be an adjunct to get objective data on how breathless someone is. There are normative values, and I just hop onto Google and look up a 6-minute walk test calculator for normative values, because it does change by age, sex, and height. But that's something you can look up. And then the last is a stair climb or any sort of exercise with oximetry. And so I'm in an office block. I get them to walk up several flights of stairs, and if they desaturate, that's very significant for me. But I get a better sense just looking at them what their breathing pattern is like. Are they using their accessory muscles? Are they walking abnormally? Have they got an abnormal gait? So I actually get a lot of information from watching people exercise in my rooms. It usually only takes 3 to 5 minutes, but if you're really struggling with a patient on knowing what to do with them, and you're in a resource limited area, that might be a good next step. When might you consider repeating things? And lung disease, if it is, or any sort of disease, if it is there, might present with breathlessness early. And if the symptoms persist or they're progressive, it may be worth repeating those investigations 6, 12 months down the line, particularly if you've hit dead ends earlier, particularly if the suspicion of disease is high, because in very early disease, sometimes your initial screening test might be normal. And I think it is worth, if you run into roadblocks, repeating things 6 to 12 months down the track if a patient is still suffering with symptoms. So I'm going to present this first case, and we've got 3 cases to present today. And we've got some imaging for each of them. And so hopefully you'll find these interesting. And all of them, the GPs did a significant amount of work in trying to figure out what was going on with the patient before they referred in to a respiratory physician. So this patient is 58 years old. She's had 1 to 2 years of breathlessness, but particularly with exercise. The GP had arranged for her to have a normal CT chest. And because she had a normal CT chest, she was referred to a cardiologist as the next step. And the cardiologist did an echo, and it was normal. And despite that, she went back to her GP, said, look, the cardiologist says everything's fine, but I still feel breathless. And her perception was that she couldn't get a full breath in. It was definitely worse with exertion. So this is her baseline spirometry, which the GP had done. And it's all within the normal ranges. So if we start with a spirometric ratio, she's got a spirometric ratio that's above the lower limit of normal, so she's not obstructed. Her FEV1 is 87% of predicted, which is within the normal range. And her FVC, it's at the lower end of the normal range, but still normal. And if we have a look at her spirometric graph here, she was able to, it was a good effort. So the FVC is not underestimated. She was able to expire for 8 seconds, and she plateaued after about 3 or 4 seconds, which was able to maintain that. And the flow volume loop looks reasonable. Her peak flow is higher than what we'd expect, but technically all of these are within the normal range. When the GP was thinking about this study, the GP thought, well, what are the next steps? So if we apply that oxygen pathway that we learned before, the airflow seems to be relatively normal. The spirometric volumes are normal. The heart, we've been told by the cardiologist, is normal. It's pumping blood and oxygen around the body properly. Her hemoglobin was normal, so blood transport was normal. So the GP, she thought, what's next? Maybe there's some dysfunctional breathing. Maybe there's an early diffusion abnormality. Remember, we haven't done any formal lung function tests yet. Perhaps there was some hypersensitivity or gas trapping that they weren't picking up on just a plain CT chest. But this patient was still very symptomatic. And she kept on going to the GP going, what's wrong? And I think it's really important that we don't dismiss, and this is a side comment to this case, but it's really important that we don't dismiss patient symptoms. The word patient comes from, I think it's the Latin, patiens, meaning to suffer. And we need to, as physicians and clinicians, need to relieve that patient of their suffering and not fob them off. And I think one of the worst things that you can tell a patient is, oh, it's all in your head, And people might say that as when they're referring to dysfunctional breathing or obesity or something like that. It's really, I find it's not particularly helpful in maintaining the therapeutic relationship with a patient. The way I explain dysfunctional breathing to patients is that there is a disconnect between what muscles are being activated and what is being useful in breathing. It's kind of like an overuse syndrome for certain types of muscles, and trying to retrain those muscles to work in a more coordinated fashion is what we need to work on. And then I send them to a physiotherapist who specializes in dysfunctional breathing. But that's something that I think patients can hear without being told it's all in their head, and they seem to respond better to treatment when that's the case. Anyway, back to this case. So the GP heard the patient, didn't ignore her symptoms, and I think ordered or took her for a walk, and she walked up 5 flights of stairs, and her oxygen sats fell from 95% to 76%. So very abnormal. So then the GP went, right, this is clearly pathology. There's something going on. The CT scan 9 months ago was normal. We've got to relook at things. And so she ordered a full set of lung function tests. And these are what she found. And you can see that there's quite a severe impairment of gas exchange capacity. The DLCO is just 46% of predicted. The KCO is 59% of predicted. And her alveolar volume, as measured by the helium dilution technique, is also mildly reduced at 77% predicted. So her lungs are slightly small. And we kind of got a suggestion of that with her reduced FEC. So the next question is, with these tests, what imaging should we order? And what's the next best test? So I might hand over to Dean. And Dean, how would you approach this case in someone who clearly has some sort of lung disease because she's desaturating? For me, the differentials would be pulmonary hypertension, thromboembolic disease, or interstitial lung disease. Those are the sort of 3 big things that will cause an isolated diffusion impairment. But Dean, how would you approach this case?
Okay, thanks, Paul. Yeah, it's an interesting one. We know that the patients had previous imaging, and that's important here because let's assume for a second that they hadn't. What would we do? Well, I think it's not unreasonable to do a chest X-ray. We might identify major pathology that obviously explains the patient's symptoms on that study. But we know that they've had a previous CT, and that previous CT was unremarkable. So let's have a look at that previous CT. This is the patient's previous study. It was performed as a standard CT chest with contrast, which is a reasonable test to do in that situation. And there are some minor changes here, but there is nothing dramatic that would explain the patient's findings. So in this situation, what we would do next? Well, I think my recommendation would be an HRCT chest, because we believe there to be something happening in the lungs. The standard CT chest has not unveiled that. If there was an option to do something functional, like a CT LVAS, then you can combine that without any additional radiation cost to the patient with an HRCT chest. So that would be my recommendation in this situation, because it's going to give us the best bang for the buck. We're going to hopefully be able to identify a cause for the symptoms. So let's go on to the follow-up study. This was performed as another standard CT chest. And on this study, we can see now there is clearly a diffuse abnormality in the lungs. And that diffuse abnormality is interstitial changes, ground glass changes, and importantly, what we would call mosaic attenuation, which often goes together with air trapping. So that's what we had over here. We have these interstitial changes. There's clearly air trapping. And our diagnosis from the imaging would be something like most likely hypersensitivity pneumonitis. And I wonder whether or not that's what we ended up getting as the definitive diagnosis.
All right, thank you, Dean. So, I mean, I think it's interesting. This is not necessarily a typical patient, but she had a normal CT a year ago, and now it's clearly abnormal. The next step was to refer to a respiratory physician. So she was referred to me, and I promptly organized a bronchoscopy with a biopsy, because we have to figure out what those infiltrates are at the base. The differentials for that infiltrate is quite broad. It can be autoimmune, might be infiltrative, it could be allergic, it could even be infection. And so bronchoscopy is pretty much essential to try to figure out what that is, because on one hand, you might have infection, in which case you need antibiotics. But on the other hand, if it's some sort of interstitial lung disease that needs immunosuppression, you don't want to immunosuppress them if they've got infection. So they almost all need a bronchoscopy. So I sent her off to have a bronchoscopy, and they did a biopsy at the same time. And it came back with a diagnosis of hypersensitivity pneumonitis, which is a type of interstitial lung disease. For some of you, you might have heard of, say, bird fancier's lung or farmer's lung. So all of those are a similar sort of pathology, where it's a hyperallergic reaction to an antigen and causes an interstitial lung disease. And the way I describe it to patients is a bit like a rash within the lung that's causing inflammation. And we can settle that inflammation down with immunosuppression. And so she got started on prednisone 50 milligrams and was quickly put on steroid-sparing agents with mycophenolate. And she's had some improved breathlessness since that was the case, and a mild improvement in her CT chest. So unfortunately, it hasn't all resolved back to normal. And often, the longer that you have these sorts of interstitial abnormalities, the more chance it's going to leave some scarring and permanent impairment of the gas exchange capacity. So the earlier we can pick it up, the better. But unfortunately, in this case, the original CT scan was normal. So I don't think in this case it actually could have been picked up earlier. But that was her case. Just coming back to her original spirometry that we did earlier, I suppose there were some very subtle changes that we might have been able to pick. So the reduced FVC, even though it was technically within the normal range, was at the lower end of the normal range. And that might give a slight inkling that she's having a process of ventilatory restriction. And so perhaps we could have repeated her spirometry serially just to check whether that had not been changing. And the second thing, which is of interest, is her peak flow. So you can see here that that her peak flow is quite high. It's far above the reference range that we've given in the flow volume curve. And that can often suggest in interstitial lung disease that the lungs are a little bit stiff. And so when a person breathes, takes a big breath in and they breathe out, because the lungs are stiff, they contract back quite quickly. And as long as there's no airflow obstruction, you get an increased peak flow. An increased peak flow by itself isn't that bad, but in this case, it's disproportionate to how high the FEV1 and FEC are. So that might be another small clue in this case. But other than that, I think the GP did a great job to get to the bottom and refer appropriately. So a few key points from this case. Firstly, that normal spirometry does not assess ventilation pattern or diffusion. And it's important to keep that in mind, that just because you do spirometry, if you do spirometry in your rooms, fantastic, hats off to you, congratulations. But don't rest on your laurels and assume that the ventilation or diffusion might be the same. Normal investigations might lead to a label of dysfunctional breathing, but it's important that you go all the way, investigate all of the causes, and consider repeating them if you've got a high suspicion of disease. The HRCT with inspiratory, expiratory, and prone views can reveal very subtle abnormalities that may not necessarily be seen on a CT chest or a CT chest with contrast. This comes back to patient symptoms, but validating a patient's symptoms can help improve engagement. And in this case, because the GP was engaged, the patient kept on coming back. The GP was listening to the patient and validating her concerns, and they got to the right answer eventually. Okay, so that's case one. That was the end of that case. I'm going to move on to the next case now, the third case, which is more quite a complex case. And I want us to think about how we might manage a patient who has lots of things going on all at once. So how are we going to optimize lung disease? How are we going to look at anemia, cardiovascular fitness, pulmonary cardiac causes, peripheral muscles, and breathing retraining? So let's have a look. This is a multimorbid patient. She's 68 years old. She's recently had a pneumonia with a hospitalization. She's a current smoker. She's on Suboxone for opioid dependence. And she's got a background of PTSD, depression, alcohol dependence, and hepatitis C. And she presents with dyspnea and orthopnea. Now, she was actually admitted under me in hospital with the pneumonia, and she was coming to see me in my rooms. I think some of this would be tricky for the GP, but she had been complaining to her GP about her dyspnea and orthopnea for some time. In hospital, we did have the luxury of an arterial blood gas, and it did show that she was mildly hypoxic with a PO2 of only 63 millimeters mercury, and she was hypercapnic as well with a PCO2 of 53 millimeters of mercury, suggesting that she's not she's hypoventilating, so not moving enough air in and out to adequately blow off her CO2. The clue, when I went back and looked at her electrolytes, the clue was her bicarb had been raised for at least a couple of years. And her bicarb was 30 and in hospital was 31, suggesting that she did have an acidosis process that was compensated, which is why the bicarb was elevated. In this case, the AA gradient was normal, at the very high end of normal, but still normal. And so when you have a normal AA gradient, it means that the ability of the lungs to absorb oxygen should be normal or close to normal. And so the reason why she's having type 2 respiratory failure may not necessarily be an airflow cause, because I think one of the things that would be easy to jump to conclude in this lady is that she's a smoker, she's had a hard life, she's got hepatitis C, she's previously abused her body with opioids. She's probably got COPD. And the GP had started her on some inhalers on spec, but she'd never actually had any pulmonary function tests. So when she came into my rooms, that was what we did. But these are the differentials that were thinking through my head when she was presenting to me after her hospital visit. So could she have COPD? Yes, she could, but she's got a normal AA gradient, so it's a little bit down my list. Opioids could be causing her to be breathless because opioids will reduce your ventilatory drive and that will raise your CO2. So that's a possibility. She was obese, and if she's obese and the opioids too, reducing ventilation, that might cause a bit of atelectasis, and that can cause some breathlessness as well. She could have heart failure because she reports orthopnea, and heart failure and pulmonary edema can also cause a rise in your PCO2, but typically you'd have an abnormal AA gradient. So, but the orthopnea does make me think maybe she's got some heart failure. She could have a pulmonary embolism. She's recently been hospitalized and immobilized, and she's more breathless when she's coming to see me in my rooms than she was before. And of course, she's got this background of anxiety and PTSD, and maybe that's contributing to her breathlessness as well. Or perhaps it's all of those things all at once. So how do we work through each one? So let's start with what I'm good at, lung function. And her spirometry is presented here. And it's pretty normal. Not pretty normal, it is normal. I mean, her FEV1 is 92% of predicted. Her spirometric ratio is normal. Her FVC is 97% of predicted. This is pretty normal. So I think from this spirometry, we can pretty much say she does not have COPD because she doesn't have airflow obstruction. So remember the trinity of COPD. You need symptoms, which she has. You need an exposure, smoking, which she has. And you need obstructive spirometry, which she doesn't have. So she cannot have COPD in this circumstance. So what is it then if it's not COPD? So we also did some lung volumes, and her total lung capacity was normal at 102% of predicted. Her DLCO was normal as well, pretty close to normal. Well, it is normal, 77% predicted, the lower end of normal, but still normal. Her hemoglobin, 174, a little bit up. So maybe she's got some polycythemia, which suggests to me maybe that hypoxia we saw is been a little bit more long-standing than we would have otherwise thought. But the polycythemia or the increased hemoglobin makes me a little bit concerned that there's been something going on for a long time. So next question is, I need to do some imaging of her lungs. So she's clearly hypoxic. She's got hypercapnia. She's got evidence of long-term hypoxemia with the elevated hemoglobin. I need to scan her lungs somehow. So the question is, which test should I do? So Dean, having a look at that case, what do you think?
Again, another interesting one, Paul. I think in this situation, my recommendation would be probably an HRCT chest. I think, again, that is going to give us our most information. You can combine HRCT chest together with a contrast study. There are technical ways that we can do that where we are able to get both the information from the dynamic test, the HRCT, as well as the information from the contrast component of the test. Normally, we wouldn't combine the two together because you can get a little bit of false positives findings in that situation. But if we were trying to reduce the radiation or the amount of visits that the patient would have to radiology, that could be one option. Part of the benefit to doing that is that you can actually look to see if there is any evidence of chronic thromboembolic disease. So if it was possible, this is one of those cases where it's the best option is to discuss it with the radiologist, particularly a radiologist who does a lot of lung imaging. And if it was possible to combine the protocols, that's how I would do it. Otherwise, the better test, I think, in this case is an HRCT chest. As it turns out, the patient had a CTPA to look for thromboembolic disease, which is perfectly reasonable as well. But the interesting finding on this case was that while there are some minor atelectatic changes that you would expect in this patient's age, there was a significantly elevated right hemidiaphragm. And I'll show you that on a different plane. You can see that this left side is normal. That's the normal diaphragm, whereas the right side, which I'll replay again, this right side, the diaphragm is very elevated. As a result, there is compressive atelectasis in the right lung. And the question is this diaphragm elevated because it's something below the diaphragm, something above the diaphragm, or is there a problem with the diaphragmatic function itself? So one other test that we can do is what's called the sniff test. It's a fluoroscopic test where we get the patient to take a sniff in. And if you see paradoxical motion of that diaphragm, then it means that the diaphragm, there's a palsy of the diaphragm, that there is a phrenic nerve injury or phrenic nerve pathology that's causing that paradoxical movement, which is in fact what this patient had. The atelectasis is what causes the reduced lung volume, and that might be contributing to some of the other findings that you have. Thanks, Paul.
Thanks, Dean. So as you can see from the imaging, she's got a really elevated right hemidiaphragm. The puzzling thing to me, if we think back to the lung functions that I showed you before, was why was her total lung capacity normal and her lung volumes on spirometry also normal? Typically, I would have expected those to be low. And it's just one of the puzzling things about this case. I can only hypothesize, or perhaps because of her smoking, she had a little bit of hyperinflation to start with, so the lungs were a little bit bigger, and the restrictive effect of the raised hemidiaphragm reduced her lung volumes to sort of a more normal range. That's the only explanation I've got, but other than that, I was a bit stumped by the normal lung volumes. Anyway, when someone has clear diaphragmatic dysfunction, the next step is to perform a sleep study, because in sleep, our breathing is really compromised because we're asleep, but particularly during REM sleep, because our brain's very active, it's getting rid of a lot of junk memory, adding a lot of new memory, we're dreaming. To stop us acting out our dreams, our brain paralyzes our body, except for 3 muscles: our eye muscles, one muscle in the ear, and the diaphragm. And so if a patient relies on their accessory muscles to breathe, that won't be there in REM sleep. And so typically in patients who have diaphragmatic dysfunction in any way, whether it's a palsy or even in hyperinflation in COPD, or a palsy in motor neuron disease, their oxygen levels should plummet in REM sleep without adequate recovery. And that's exactly what we saw on this sleep study. So her baseline AHI was 95 events per hour. Remembering that the normal is anything less than 5, anything more than 30 is severe. So she's almost triple severe. Her REM AHI was 114 events per hour. And her oxygen levels, her mean oxygen was 79%. And that fell to a nadir of 72%. And over the course of the study, we measured her CO2. It was an in-lab study. She wouldn't be appropriate for a home-based study with her type of disease. And her CO2 did increase across the night because she was hyperventilating. She wasn't moving enough air to blow off her CO2. So very abnormal study. So we admitted her after that study, and we started her on bi-level ventilation for type 2 respiratory failure. And with the aim to try blow that CO2 away, try and improve her oxygenation overnight. We also got her on a smoking cessation program, which I've known her now for 7 or 8 years, and it's come and gone, but she really tries. We have reduced her Suboxone dosing in case that was contributing to her hypoventilation as well, and reduced that from 24 milligrams down to 16 milligrams. And we started some inspiratory muscle training, and that's with a resistance device that you're breathing in, and the aim is to try strengthen the muscle. If it has any neurons left to it, I suppose, any synapses, to try and improve that muscle strength. Unfortunately for her, it didn't help because that diaphragm had been long gone. Interestingly, she was never started on an inhaler. She never had obstructive spirometry, and I don't think she would have benefited from an inhaler in that setting. And so over the course of the next few years, I've seen her that she's done quite well. She's not as breathless. Occasionally, she gets fed up with the machine and she doesn't wear it for a few days, and her CO2 rises and she becomes confused and gets admitted to hospital. But overall, she's doing pretty well. So how do I think about this case when we're trying to correct things? So what I want you to take away from it is when the symptoms don't map cleanly to a single diagnosis, you've got to challenge your own beliefs and think, right, this patient, although she's got all the risk factors for COPD, she clearly doesn't have COPD. What else could be going on? And if she has persistent breathlessness, how do we then improve it? Ordering lung function tests to help identify your lung volumes and diffusion compromise is really helpful. Particularly, you saw in that first case that I presented how important that was. And having a good relationship with your radiologist to interpret subtle CT changes that you might find. As an aside, for case study 3, about a year after we started on bi-level, she presented again to the emergency department, very short of breath. And I was thinking, oh, what has she got now? And the ED ordered a CTPA and she had clots. So she ended up having PEs as well. So that's an aside. Just because someone has breathlessness for one reason doesn't preclude them from having breathlessness for another reason later down the track as well. So when we're thinking about her, not necessarily for her because she's already polycythemic, but for other patients who are anemic, you might think about some iron repletion. We need to think about cardiometabolic optimization. For her, she was very deconditioned because she'd been breathless for so long, and I referred her to pulmonary rehabilitation, predominantly because of the diaphragmatic dysfunction. They helped with that inspiratory muscle training. And every time someone presents with a worsening of their symptoms or a change in their symptoms, we really need to reevaluate the diagnosis timeline and whether something is new or whether it's an exacerbation of something old, so that we can fully explain the symptoms that a patient has. So, key teaching points. Patients, when they have breathlessness, in my experience, tend to have accumulated breathlessness problems. A whole lot of small things will add up to present with a significant dyspnea. An improvement doesn't come from just improving one domain. It comes from optimizing each one of those domains. So in this final case, it was improving her sleep apnea, improving her diaphragm dysfunction, getting her rehabilitation, considering whether she needed an inhaler or not. In this case, not. And we also got her checks on her heart to check that she hadn't developed pulmonary hypertension. She had not. And I think it's important not to jump to conclusions and to try and get objective evidence for your diagnoses rather than prescribe an inhaler, which can sometimes be the easier thing to do that may not necessarily work for the patient. So overall, some key teaching points from the talk today. So I think there are a huge range of tools available to you in the GP community to explain and explore a wide range of differentials for patients with persistent dyspnea. You can use a combination of basic spirometry, pathology, targeted radiology, and just being very clinically observant. And when things don't fit, to try rethink what it is. Don't try fit a diagnosis into the picture. Keep your differentials broad. And if stuck, if patients continue to have symptoms, go back to the basics. Think of that basic model of oxygen delivery, starting at the top, working all the way down to the muscles, from breathing in and out, across diffusion into the blood, thinking about anemia and the and oxygen carrying capacity, that blood pumping around the body by the heart then pumping that to the muscles, and the muscles utilizing that appropriately. If you think through that, most of your differentials should be teased out.